Chronic knee pain and a fear of falling, a case study by Alicia. Just imagine, have you ever felt a pain so severe in your knee that it hurts every time you take a step? I know I have. What about those patients we witness stumbling into our clinics who have pain so severe that it prevents them from participating in essential everyday tasks, or even makes them afraid that they will fall? Today, we're going to take a look at a 7-year-old patient who has severe knee pain and a fear of falling. First, we're going to do a little overview of the patient case and all the patient details. Next, we're going to look at the definition of degenerative knee disease and how it relates to this patient. We're then going to review kinesiology principles that apply to the patient along the lower extremity kinematic chain. We're going to identify and guide the patient through all appropriate phases of rehab. We're going to incorporate rehabilitation principles into effective therapeutic interventions. And lastly, we're going to look at the patient's outcomes and long-term goals for continuity of independent rehabilitation for long-term symptom management. Now, let's meet our patient, Miss T. Miss T is a 7-year-old who has diabetes, diabetic neuropathy, hypertension, and degenerative disease of the knee. She also expresses a fear of falling. After the initial screening and evaluation, we have determined that Miss T has had 2 falls within the last 12 months. She has difficulty rising from the chair for the tug test, and with a score of 15 seconds on the 3-meter tug test, she is at a high risk of falls. Currently, she's taking 2 antihypertensive medications. She's taking glucagon for her diabetes, Tylenol with codeine for pain, and Valium for anxiety. She has adequate vision with the use of eyeglasses. Her heart rate, heart rhythm, and blood pressure are all within normal limits. Miss T is unable to rise more than 1 time in a 5 times chair rise test. The activity-specific balance confidence test indicates a fear of falling and that the patient is self-limiting, which is causing limited mobility and activity participation. The Simmons-Weinstein monofilament test determines that Miss T is unable to sense 10 grams of pressure and has a lost sensation bilaterally. Miss T's manual muscle test in the lower extremity is within functional limits, and her functional performance test indicates that the patient is unable to rise from chair without using her arms. She is also having difficulty ambulating greater than 100 feet. Miss T does not like to exercise, and she reports increased pain secondary to exercising. But what is degenerative knee disease? Most of the time we think of this as osteoarthritis. The knee happens to be the largest synovial joint in a human, which is composed of osseous structures, cartilage, ligaments, and synovial membrane. This joint is a high-use and high-stress joint, which makes the knee a frequent site for painful conditions such as osteoarthritis. Osteoarthritis etiology is still under review, but we can only speculate its etiology. Osteoarthritis is classified into 2 groups, primary and secondary. As I said before, the exact etiology is unknown, but we do know that it's a multifactorial entity involving either trauma, mechanical forces, inflammation, biomechanical reactions, and metabolic derangements. When patients have pain due to osteoarthritis, the pain is derived from the non-cartilaginous components due to the non-vascularity of the joint. Osteoarthritis inflammation is chronic and low grade. Synovitis is commonly found in patients with osteoarthritis. The synovial fluid itself contains inflammatory mediators, which forms a matrix that breaks down cartilage, secondary to collagen destruction. This extracellular matrix releases molecules in response that are recognized by the innate immune cells, which leads to a prolonged and dysregulated inflammation response. Therefore, we then have tissue destruction. Mechanical loading is also of concern with patients with osteoarthritis. The abnormal loading can be caused from obesity, immobilization, joint instability, overuse, or even trauma. High impact loads cause damage to the articular cartilage. They increase the cellular activity within the joint. They also increase the tissue hydration and bone remodeling. We also know that mechanical loading promotes this extracellular matrix and involves the inflammatory mediators and cytokines in its response. Mechanical signal transduction in the cartilage. This basically is stating that secondary to the loading response, this extracellular matrix becomes flooded with signals that impact stress, strain, fluid flow, fluid pressure, electrokinetic effects, and changes in the tissue's fixed charge density. This is going to affect the filtration of the cells and the tissues and osmolality and all these factors that are going to prevent nutrients and things from replenishing the tissues. We also know that mechanical alterations that occur in these microenvironments may further alter the cell's response to loading. So these mechanical alterations are inhibiting the cells from functioning properly and tolerating these loading responses. Now that we have an idea of what's going on inside Miss T's knee, involving the things that we can't see, let's take a look at how kinesiology plays a role in Miss T's life with her knee pain. To understand the things that are going wrong with Miss T's gait, we must first understand what normal gait looks like and how the normal knee kinesiology affects the joint. First, the knee joint is made up of 3 axes of rotation and 6 degrees of freedom. Along each plane or axis, the knee can rotate and translate respectively, which allows for a total of 12 motions. The greatest amount of angular motion occurs in the sagittal plane. This is where we get our flexion and extension from. There are small degrees of motion that occur in the frontal plane, or what we call coronal plane. This is where abduction and adduction occurs. There are also small degrees of motion that occur in the transverse plane, and we get our internal and external rotation. If we break this down even further and take a look at the individual planes, we can look at the kinematics and kinetics of each plane. The sagittal plane, the kinematics of this plane begin in nearly full extension at the initial contact phase, progressing to a biphasic pattern of sagittal motion. From the initial contact to the loading response phase of gait, the knee flexes to approximately 20 degrees. This is the actual peak knee flexion angle at this point. Then the knee begins to extend during mid-stance to nearly full extension, progressing to flexion during pre-swing and swing phase. 60 to 70 degrees of flexion are required to complete the swing phase, concludes most researches. During the initial contact, the ground reaction forces are anterior to the knee, creating external extension moment, or torque, which is counterbalanced by brief activation of hamstrings and the gastroc. During the loading response, as the knee flexes, vertical ground reaction forces move posterior to the knee, generating an external knee flexion moment. Internal extension moment through eccentric activation of the quads controls the amount of knee flexion. During the mid-stance phase, the knee begins to extend. The vertical ground reaction force is at the knee center or approaching the knee center. The knee extension is achieved when the quad activation starts to decrease. The femur then advances over the stabilized tibia, which is stabilized by the soleus, and knee extension is driven primarily by the body's momentum. The lower extremity progresses through terminal stance and pre-swing, preparing for the swing phase. Within the frontal plane, the normal knee experiences about 8 to 12 degrees of motion during the gait cycle. This plane is used to maintain balance over the stance limb during gait. The peak abduction or valgus angle occurs from the point of initial contact to loading response during the gait cycle. And peak adduction or varus motion is actually achieved during the swing phase. Muscular stability is provided from muscles in both frontal and sagittal plane for the frontal plane. The IT band, the long head of the biceps femoris, play a large role in the stability of the frontal plane. The upper gluteus maximus actually promotes tautness of the IT band, which is why the IT band is included in here. It's not necessarily a muscle, but it does play an effective role rather on the stability of the frontal plane of the knee. A co-contraction of the hamstrings and quadriceps makes up 80% of the medial and lateral stability during dynamic tasks of the frontal plane of the knee. Lastly, the transverse plane is similar to the frontal plane in the fact that we're only going to see about 8 to 12 degrees of motion during the gait cycle in this plane. During initial contact, the femur is externally rotated on an internally rotated tibia, and during the loading response, the tibia progresses to maximal internal rotation. Transverse stability is provided by static structures around the knee joint, not necessarily by a muscle, but more so we're talking about our ligaments and things like that. The lack of dynamic stability makes injury to the static stabilizers more debilitating during gait and limits stability to resist internal tibial rotation at the loading response is primarily from the TFL and the biceps femoris. So what happens when these kinesiology concepts go wrong in just the knee joint? Rowe et al. 2019 demonstrates that changes in gait mechanics in the knee joint have a strong effect on the range of motion, coronal motion arc, and joint moment of the ankle and hip joints. Ankle varus moment is 50% higher in osteoarthritis patients and can lead to an increased secondary osteoarthritis development and pain. Ankle subluxation is common in patients who have knee osteoarthritis. It is noted that there have been 2 degrees of hip flexion contractures found in osteoarthritis patients, and these patients had a flexed posture, which obviously if you're stooped over and bent over in that fixed position, your hip flexors are going to be contracted. This causes a constant contraction of the quadriceps femoris, resulting in increased pain and increased quad loading during the gait cycle. Coronal motion at the knee is 55.6% less in osteoarthritis patients, and is also the coronal motion at the hip is also decreased, which results in an unstable gait pattern, similar to what we would see in the Trendelenburg gait. We have the patient who is leaning over to their stance leg or towards their stance leg so that they can achieve that stability to progress their other leg. Coronal moment is higher in the knee and ankle joints. Therefore, this creates an increased medial joint loading and an increased osteoarthritis progression. Again, we're going to have medial loading on the medial aspect of that knee, going to keep applying pressure, wearing away our tissues, and ultimately Wolff's Law will take an effect, and people often generate bone spurs at the knee as well. Abnormalities in the coronal plane include a varus thrust. During the stance phase of the gait, the patient thrusts laterally, which creates tensile forces on the lateral knee and compressive forces on the medial knee structures. Again, we're going to picture this as a patient who has bowed legs. That's exactly what it's going to look like. You're going to have that increase compression of the knee joint in the medial space and taut ligaments around the lateral aspect of the knee. So now we know what to look for when we are observing Miss T in the clinic. Even though there are not specific phases of degenerative knee rehabilitation as compared to surgical repair or sports-related injury, we can take osteoarthritis patients through 3 general phases of rehab. A combination of patient education, exercise, weight loss, and community resources are recommended as evidence-based guidelines for the treatment of degenerative knee disease. Phase 1 of Miss T's rehab will begin within the first week. This is the phase where we will introduce an abundance of patient education, and we will start to kind of dwindle into phase 2 by adding some therapeutic exercise and focusing on pain relief. When we begin to think about what patient education would benefit Ms. T the most, we can look at her medical history. We know that Ms. T is taking a handful of medications, some of which are associated with an increased risk in falls, such as Valium. We also know that Tylenol with codeine and Valium are on the list of potentially inappropriate medications for older adults. With this information, we can educate the patient about the potential polypharmacy occurrence, and we should also and have educated the patient's physician about what we are noticing as well. Ms. T has diabetes and diabetic neuropathy, so it's also very important for us to educate Ms. T on managing her H1AC levels and keeping a record of those and bringing them into therapy so that we can ensure that she is managing those as well. We can educate her on appropriate foot care. We have noticed that she has 2 bilateral ingrown toenails. So what we're wanting to do is make sure that she understands that she needs to keep her skin hydrated, keep her toenails trimmed, try to avoid cutting her toenails too short, leading to an infection. We can also show her how to take a handheld mirror and create independent skin check assessments to make sure that she's not developing any sores or open areas on her feet. As mentioned before in phase 1, we will also start to implement a few strengthening exercises and address Miss T's pain. Phase 2 is where we're really going to dive in and really implement a strong strengthening program and address her pain management. Usually this phase of rehab will last from the 2nd to 8th week of therapy. As we begin to decide which exercises would benefit Miss T, let's look into the Otago program. The Otago exercise program was founded and implemented at the University of Otago in New Zealand. The program became used and studied in the mid-late 1990s and proven to decrease falls and fall-related injuries in high-risk older adults by 46%. Many outcomes for its use in the United States include improvement in functional outcome measures, improvements in perception of ability to sit, stand, kneel, and walk, and improvements in balance confidence and fear of falling. Right there alone, that tells me that this program would be great for Miss T. Participation requirements of the Otago program include attending a minimum of 5 sessions over an 8-week period with a provider of OEP, which could be a PT, PTA, or any other community provider with geriatric exercise expertise. However, it is highly recommended to have a PT provide consultation services as necessary, and we'll see later that one of the primary goals of this program is to ensure correct mechanics, to make sure that the patient is receiving all of the benefits of the program. Patients must complete their OEP plan for up to 30 minutes a day for 3 days a week, and patients must complete a walking program for up to 30 minutes a day for 3 days a week. Over an 8-week period with Miss T in the clinic, we began to incorporate exercises from the OEP. All of her exercises are completed in a standing position to increase balance, proprioception, and elicit ankle joint writing reactions. We also address a little bit of glute strengthening in her program with standing hip abduction and extension, as we saw earlier that patients with osteoarthritis tend to mimic that Trendelenburg gait pattern. We start her exercises with 1 set of 10, and we gradually increase them to 3 sets of 10 each as she can tolerate. Miss T's pain is decreasing, so therefore we are increasing her exercises. Some additional exercises that we have added as she's able to tolerate include heel raises and toe raises, a tandem stance, which we can further challenge her proprioception by adding a proprioceptive pad or any other surface that she could stand on. She's doing single leg stances, chair raises, wall squats, and then we've even began to incorporate a little bit of gait training. We're doing dual task gait training, which is where we have her walk at a consistent cadence while she's distracted by either talking or doing some other type of activity. She is participating in forward walking, backward walking, and sidestepping. We are doing 2 sets of 10 steps of each walking exercise. After Miss T demonstrates great carryover of her initial exercises, she has progressed through all 17 OEP exercises, which you can see here, with the therapist paying careful attention to Miss T's technique. If we look at the patient's overall therapy goals and current mechanical deviations, we can see that the Otago program addresses all of our issues, including lower extremity strengthening, which will end Miss T's pain cycle. We are addressing balance and neuromuscular reeducation, and this program also gives us the opportunity to address and correct Miss T's abnormal gait deviations that are secondary to her osteoarthritis development. Some key elements of the Otago exercise program include a series of warm-ups. The patient must participate in a minimum of 5 sessions over an 8-week period. There are a total of 17 OEP exercises which focus on strength and balance that must be completed 30 minutes 3 times a week. And Ms. T must also include her walking program as she is able to tolerate up to 30 minutes 3 times a week. I previously mentioned neuromuscular reeducation. But why is that so important for Miss T? We must remember that the task of balance includes detection of body motion by sensory systems, integration of this sensory information by the central nervous system, and finally execution of an appropriate motor response. When we look at neuromuscular re-education and apply it to Miss T's case, we can see that we can provide neuromuscular re-education through the form of electrical stimulation and through neuromuscular exercise. Neuromuscular electrical stimulation, or NMES, has been proven to improve quad strength in healthy individuals and for individuals with various knee pathologies. The stimulation activates the type 2 muscle fibers at low contraction intensities, which this bypasses the voluntary inhibition and overcomes that central activation failure, also known as arthrogenic muscle inhibition. NMES has also shown positive post-treatment effects on decreased pain. We know that knee pain often reduces the patient's adherence to exercise. As we saw in Ms. T's initial evaluation, she thinks that exercise increases her pain, which continues that vicious pain cycle, leading to further increased muscle weakness and increases in pain. When we apply the concepts of neuromuscular re-education to exercise, we're looking on a principle that is based on biomechanical and neuromuscular principles. These principles are aimed at improving sensory motor control to achieve functional stability. Neuromuscular exercise is used for impairments in proprioception, muscle activation deficiency, and functional knee instability. The primary principles that surround neuromuscular exercise are that we want to have our patients using active movements and synergies. We also want to incorporate bilateral transfer effect of motor learning, which means starting the patient out doing an exercise on a non-affected leg and then carrying that over to their affected leg. We want to use closed kinematic chains with muscle co-activation. We also want to focus on postural functions and postural reactions. Again, we want to make sure that the patient is standing upright, that everything is in a line the way that we want it to be. And then we need to focus on challenging those positions with perturbations or different forms of proprioception underneath the feet. And last but not least, and it's probably the most important, we need to address quality over quantity. For neuromuscular re-education to work effectively, we have to be training the body to do the motions and activate the appropriate muscle groups. We don't want these patients just going through exercises just to go through them. We want them to benefit. The ATEGO program already incorporates many, if not all, of these concepts, but we must make sure that Ms. T is performing her exercises while following all of these primary principles of the ATEGO program. At this point in Ms. T's rehab, she is successfully completing all ATEGO exercises with near perfection. It is time to refer her to community resources, which can help her maintain her new lifestyle and help her continue to make a strength gain. During this phase, the therapist is ensuring that the patient is completing exercises correctly with focus on posture and mechanics. At this point, Ms. T has completed over 40 hours of balance exercise through PT and with the incorporation of the OEP in her home exercise program. We make phone calls to Ms. T to ensure that she is complying with her exercises at home and to see if she has any questions or any uncertainties. We have referred Ms. T to a community program called Matter of Balance. This is a program that is used to address her fear of falling, which she still continues to have a little of. After this program is completed, Miss T is referred to the local YMCA Senior Center for admission to the Fall Proof program. Since Miss T is discharged, she has been released into the community to participate in various balance and strengthening programs with her peers. She is doing great. She has successfully completed the Matter of Balance program. She continues to complete 30 to 45 minutes of Otago-inspired home exercises 3 times a week. Miss T is much more confident in her balance, secondary to an improved score on the activity-specific balance confidence scale. And she has even begun the Fall Proof program at the YMCA and checks in every week at the physical therapist satellite clinic at the YMCA. As we wrap up our case study, there are a few points I want you to remember. First, when that patient first walks into the clinic and complains of having knee pain, we need to treat the patient, not the diagnosis. We know that Miss T has osteoarthritis, but that did not limit our treatment for her. We must incorporate the entire kinematic chain into the treatment session. We need to look above and below the source of pain. We need to focus on the stability of the ankle and remember righting reactions are a must for balance. For Miss T and all patients, really, we need to focus on strengthening the musculature around the joint. We go back to our primary PT and PTA concepts that we need to have stability before we can have mobility. Do not forget that sensory motor input and output declines with age and disuse. So these concepts should always be incorporated into the elderly population's treatment plan. And last but not least, make sure to utilize community sources and offer an abundance of patient education for a continuous healthy lifestyle and a patient rapport that you'll never forget. Thank you for watching.